They want it to just be gone. They want it to not be a part of who they are. They have to get through that sort of deer in the headlights period where they like hit a steady state. And then all of a sudden they start worrying about, what does this mean for me? Like, what does this mean for who I am? What does this mean for my future?
Hi everyone, welcome back to this week's episode on Take a Pain Check. I'm so excited to have Dr. Lawson joining me today. Hi, Dr. Lawson. Can you give me a brief introduction about yourself? Tell me a little bit about your education, your career, and what you've been up to recently.
Hi, I'm Erica Lawson. I'm a pediatric rheumatologist at the University of California, San Francisco. I was one of those really weird kids who decided I wanted to be a doctor when I was like 7, um, and kind of stuck with it. So, which I always felt actually very lucky for in a way, because like figuring out what you want to be when you grow up is kind of hard. And I sort of just had this thing that I was like fixated on, and then I did it. Um, I grew up in Michigan, and I don't have any doctors in my family, so I had to really kind of figure it out along the way in terms of like what this whole process looks like and what the training process was going to be like and what the career was going to be like. Um, I work in academic medicine, as a university physician, which I'll talk more about later. And I certainly, when I started down this journey, didn't even know that that existed, let alone that it was a thing that I wanted to do. But I did undergrad at the University of Michigan. And one thing I had started doing when I was in high school was volunteering in hospitals, just to I just enjoyed spending time there and sort of, thinking about what I wanted to do in the future and getting used to what it was like to just work with patients. And so when I was in college, I was volunteering in the recovery room of the operating room at Mott Children's Hospital, which is the Children's Hospital of the University of Michigan. And there was a urologist there, a pediatric urologist named Dr. David Bloom. And I remember one day one of the nurses said to me as I was like stocking drawers in the recovery room, she's like, "You should go talk to Dr. Bloom. He'll take the volunteers back to the operating room if you want to." And this was back in like the late 90s, early 2000s, before there was HIPAA. Things are like more complicated now, but I met Dr. Bloom and I said I would love to observe some surgeries. And so I ended up actually developing a relationship with him where I would come in really early in the morning, like once a week. All my roommates would be sleeping. It was like college, and I was leaving at like 5:30 a.m. to go over to the hospital when like the entire universe was asleep. Um, and I would observe surgeries with him, and I actually ended up writing a paper with him on the history of testosterone. So like learning about how testosterone was discovered, all this like really old nerdy stuff. And I was an English major, so I loved writing, and it was a really fun project. And I just spent a lot of time with him, and I learned, I think, a lot of practical things from him, and really got to like see his career in like academic medicine like through his eyes. And there's still things that he like taught me that I remember today. So I ended up publishing this paper with him in the Journal of Urology, and it really changed my life in a way. Not only did I get into med school, I actually ended up getting a full ride scholarship, which I attribute in large part because he took me under his wing and gave me the opportunity to do things I wouldn't have done otherwise. So I think that is an animating feature in my career is that, I've really benefited from people who saw promise in me and mentored me and gave me opportunities I wouldn't have been able to find on my own. And so I try to do that for others when I can.
As a rheumatologist, do you find that your background in English has been very helpful?
I actually think it is. And it's funny back when I think it's more common now than it used to be that people pursue different things. I think back when I was applying, it was more common that you were like a biology major and all you did was like science, science, science. And I knew that I wanted to be a doctor. I was like very interested in that role, and I found science really fun and interesting. But I also love to read and I love people's stories, which is a huge part of being a rheumatologist. So I actually feel like there's great alignment there. Like so much of being an English major is about understanding like narrative and people's stories. And it's about learning to be a good communicator and a good writer, which is good no matter, what field you're in, especially in academic medicine. I've written grants my whole career, whether that's for supporting research or for supporting trainees in fellowship. And so I think also like whatever you're going to do in life, being able to write well is always useful.
And what led you to rheumatology? Because you were getting some experience in the urology field. and
Yes.
just volunteering in healthcare. So how did you lead to saying, I'm going to become a rheumatologist?
Yeah. So even though I had this early exposure to surgery, which was super interesting, I knew I didn't want to be a surgeon. I knew I wanted to do something more where I was like spending time in clinic and sort of interacting with patients. And when I was, so I went to medical school at Washington University in St. Louis. And when I was in my last year, I did a sub internship, which is like when you're a senior medical student and it's sort of like the most responsibility that you get before you move on to residency. And I did it in cardiology, and I spent a lot of time on the inpatient floor. So with kids, young kids, and babies and their families who are recovering from that were born with genetic heart defects. So they were born with hearts that were not shaped properly, and they were undergoing surgeries, often multiple surgeries, to repair that process. Um, and they were on a long road. A lot of them were actually needing a series of surgeries and they were recovering in the hospital for a long time. And I loved the process of like working with those families through their recovery on this journey, and getting them to the point where they were well enough to go home. And also really liked thinking through like the physiology of the heart. And so I started residency and thought I was going to be a cardiologist. And during my intern year, I did a cardiology elective. And I remember I was just coming off of working nights in the emergency department. So my days and nights were all flipped. And I had just come back into like working days. And the cardiologist that first day had me reading echocardiograms, which is so ultrasounds of the heart that they do. And it's like a very specific skill to be able to interpret these. And so I was sitting in this dark room coming off of nights with someone who was sort of like grilling me on how to read this ultrasound. And by the end of the rotation, I realized that cardiologists not only did the work that I had really enjoyed, which was like taking care of these families on the inpatient floor as they were recovering from surgery, but they also spent time being radiologists, so reading these ultrasounds. And they spend time being surgeons, actually, when they're doing cardiac catheterization. So they actually put wires up into the heart and then they can like balloon things open and they can repair valves and do stuff that way. So it's very procedural. And so I actually, by the end of that time, realized like this is actually probably not for me because I don't really like being a radiologist and I don't really like being a surgeon. And so my lesson from that is whatever you're going into, it's good to understand like all the different aspects of it. You might just see like a slice of something and think it's really fantastic and not realize like that's not the whole picture. So good to, like whatever you're going to go into, to just like talk to different people who are thinking about, or different people who are in that role and have like different versions of that role and understanding what it looks like. So after I decided I was not going to be a cardiologist, I really wasn't sure what I was going to do. I had kind of moved away from the idea of picking just like one organ. Like I didn't want to just be a kidney doctor or just be a heart doctor or just be a lung doctor. I was more interested in the whole person. So I thought maybe I would just be a pediatrician. And then my advisor, who actually was a cardiologist, was like, Erica, I could see you doing rheumatology, which was not on my radar at all. I was like, okay, I'll do an elective. And lo and behold, I completely loved it. So I am always grateful to that advisor for pointing me in that direction because I never, ever would have found it otherwise. Um, and that is, in short, how I became a rheumatologist. I did end up, by the time I figured it out, I had a little extra time. It was like too late for me to apply for fellowship. So I had 1 year between my residency and my fellowship where I actually worked as a pediatrician, which was a wonderful year that gave me a lot of like really good skills. And was really actually, I was in a way, I was grateful that I ended up having that extra year because I think I learned a lot having a year out in the real world before I went back to training.
That's so interesting. Thanks for sharing your journey. And I think it's so interesting for patients that may want to even become a pediatric rheumatologist or just anyone watching, knowing that there are different pathways to becoming a doctor and it might take different timing and a lot of time or less time for different people. Like it kind of just depends. And from what it sounds like, you had a unique path to getting there as well and getting that exposure.
There are so many different paths, and like our jobs can look so many different ways, which is fantastic because I think it really affords you the opportunity, if you kind of dig into it, to really try to understand. I always encourage my students and my trainees to understand like what brings you joy, like when do you have flow? When do you feel like this is like what I am meant to do, and find the job where you can do more of that.
And it sounds like for rheumatology, it's more of like looking at a person as a whole. I mean, we should be doing that for all diseases, but it mostly focuses on different aspects of your body depending on like the condition you have. So, can you talk a little bit about what makes rheumatology different from some of those other disciplines, or what kind of excites you about it?
Yeah, absolutely. I always tell people that I'm half pediatrician and half detective, because rheumatology does involve a lot of problem solving, which is part of what I find so super fun about it. The other aspect that I really love that actually, harkens back to when I was doing that sub internship, taking care of these families recovering from heart surgery, is chronic care. So not just like someone comes in, they have a problem, you fix it, and you send them on their way, but really when you get to develop relationships with families and travel with them on their journey. That to me is just one of the most amazing parts of this job and something I really treasure.
That's great. Thank you for sharing. So, from your perspective as a doctor, what's a big thing that most young people struggle with when it comes to being diagnosed or even managing their condition?
Totally. It's always so interesting to me to watch the process that people sort of go through. And depending how old, the person is when they get diagnosed and how sick they are, like especially, some of my teens and my young adults, it's like something's wrong with them. They don't know what it is. They're sort of in this like crisis state. And then finally we get to a diagnosis and we're like, okay, this is how this is what you have. We're going to take this medicine. And, folks are aware, probably most of you probably, that for the most part, our rheumatology medications don't work instantly. So there's a bit of a process there. It's not like you take a pill one day and then the next day you feel perfect. And so they start on this journey of, getting better and taking their medicines. And at the same time, they are figuring out how to sort of bring that diagnosis and that new thing about themselves into their identity. And it's always interesting to me to see how some young people do that like quite easily, and other people really struggle with it or really push against it, that they don't want this to be a part of who they are. Or they keep it like very separate from themselves. And I do feel like the people who are able to sort of see this as like part of their self, their whole self and part of their journey, and to accept it often have a smoother road. I think that the folks who really try to other their illness and say like this is not me, um I see more often have a hard time like taking their medicines regularly, or they might be more likely to just like stop their medicines because they want it to just be gone. They want it to not be a part of who they are. But it's a long journey, right? And I definitely have, it's always interesting to see like some families, they have to get through that sort of deer in the headlights period where they like hit a steady state. And then all of a sudden they start worrying about, what does this mean for me? Like, what does this mean for who I am? What does this mean for my future? What does this mean for my child's future? So, and that can hit sometimes like 2 years in, that like all of a sudden, everybody realizes that like we're here for the long haul. Like this isn't gonna go away. And so yeah, everybody's journey is a little bit different. But I think trying to like be patient with yourself, like put one foot in front of the other, and know that like the journey is long and we have amazing medicines and amazing communities, and there's a lot that I think like in many, many cases we can, get people physically back to like such a better place, which is amazing and wasn't necessarily the case in rheumatology like 40 years ago. So I feel really grateful for that there's so much we can do to help folks. Um, but I think, really helping people to understand, like my advice for patients is really like to be patient with yourself and be patient with the process. Um, and try to find, community and be accepting of your illness. I mean, it's interesting. I do have some patients that, nobody would obviously want to be diagnosed with a rheumatic disease, but I do definitely have patients who feel like I can't imagine my life without this. Like this has made me stronger. It has made me better. It has like changed who I am, in some really meaningful ways, which I always find really inspiring.
Yeah, it's interesting to see the different levels patients are at when they're diagnosed. I think for me,
Mhm.
like being diagnosed at 13 with JIA, I found it really hard to accept my diagnosis, and I was kind of in that denial period, like some of the patients that you might see. And then it took me a while to realize I had to learn how to advocate for myself, and then I learned how to advocate for others. And I do think, like you said, it is a pretty long journey and it takes a while. And I would
Mhm.
kind of echo like the patience part of it. I think it does, it definitely gets better. Like for me, at least, and I think a lot of patients I've talked to, you learn how to adapt with the disease and find a community, which I think is really, really great compared to when you're initially diagnosed and you don't really know anyone and you don't know what you're doing and you don't know how your life will change. I mean, for me, I had this mentality that my life was over and I wouldn't be able to do all the normal things that other kids would do, but that's not true. I think I learned that, I have other things that I like now and I wouldn't be doing this podcast with you if I wasn't diagnosed. And so there's so many things that happen just because of this one diagnosis. And I think it might be the same for other people as they grow older.
Think that's true really for everybody in life. It's like it does, I don't know, as you move through things, you gain wisdom, you gain perspective, and it does make everything feel more manageable.
Exactly. So, as a healthcare provider, because there's just so much going on, I'm wondering if you've ever had, I mean, you probably have had like periods of stress or anxiety. So, what do you do during those times where you're like unsure of a diagnosis or you're like stressed? How do you manage like stressful situations in the workplace?
Yeah, that's a great question. I mean, I'm really lucky to have a fantastic team. So I work at UCSF where we have now 11 attending rheumatologists, which is actually quite a big group for a pediatric rheumatology practice. And it's a really diverse group as well. A good chunk of us did our rheumatology training here at UCSF, but we have someone who trained at Boston Children's. We have someone who trained at the Children's Hospital of Philadelphia. So we do have folks who have sort of different experiences and backgrounds, and then everybody does different work too. So we have folks who are clinical researchers and basic science researchers, and one of my colleagues is a pain specialist, which gives me a really wonderful sort of diverse cohort of people to go to when I'm not sure what to do. Um, and like everybody's just very supportive of each other. So I think just there's can't understate how important it is, like when it comes to managing work stress, to have really wonderful colleagues who are, and we just have a culture of like taking care of each other. Like if someone's kid is sick and you can't come into clinic, like three people will be like, I can come cover your patients. That's just like how we operate. So that for me is for sure, in terms of what helps me to manage situations where I'm not sure what to do. It's very much leaning on my smart and wonderful colleagues.
That's amazing. And are there any allied healthcare professionals that work in your workplace as well, like physios, OTs, social workers?
Yes, we have three incredible social workers in our practice, and two fantastic nurses and two nurse practitioners, and they are a huge part of that too. Our nurses are amazing at navigating systems issues that I would get totally overwhelmed by. So like when those things come up, I go to them and they just know how to like make things happen. They know how to like get that infusion set up when I'm like banging my head against the wall. So I really, really appreciate them, dealing with insurance authorizations. And then when there's complicated social situations where I'm like not sure what to do, our social workers are amazing. And I mean, all three of them are fantastic. One has been here longer than I have, and I swear she's like half trained as a rheumatologist. Like she'll like come in and tell me what they talked about on rounds just because she's been doing this for so long that she knows has just learned a lot of the medicine too. But they are, an incredible resource. So we're very, very lucky in terms of the interdisciplinary team that we have.
And then also, I guess a big part of being a pediatric rheumatologist is also transferring your patients to adult rheumatology care. So, can you talk a little bit about how that process works in your hospital?
Yeah, so I got interested in transition actually quite early on. I was just it was almost to what we were talking about earlier. It's just was always interesting me to see the different ways that people dealt with their condition, how they owned it, how they didn't own it, and how some people would be like, okay, go home and take these medicines, and they do like exactly what they told you told them to, and they come back with all their ducks in a row. And then other people, it was like it just wasn't happening. And so trying to understand like what that was and why that was and how I could be, a better doctor for those patients. Um, in terms of how we handle transitions, so and now many years ago, began a process collaborating with our social workers to create a structured transition process. And the six core elements of healthcare transition, your listeners may be familiar with. If not, they're great to look up, is a organization through the National Alliance of Adolescent Health that has created a sort of structured like framework for the transition process that I find to be very helpful. So we used that as sort of our backbone for creating our own process. So began with creating a transition guideline for our practice. So we have a lovely handout that we give to our patients that sort of explains how transition, like how the transfer process works and like what their responsibilities are and what are the places where we will be able to help them. And then we keep track of the patients in our practice using technology through our electronic medical record. We run a search once every 3 months or so for all the patients who are 19 and a half or older. And those are the patients that we then start targeting for getting ready for transfer. Doesn't mean we aren't talking about transition and skills building long before that, but I think when we started this process, what I was most worried about is patients who are aging out of our practice. So depending on the kind of insurance they have, for some of our patients, actually like after their 21st birthday, they cannot get, they can't come back and see us anymore. And I was worried that if we were not getting those patients ready with like a plan before then, that some of them were just disappearing into the ether. And that was what I think we wanted to really make sure wasn't happening. So even though the earlier transition stuff is important, we were really very focused on making sure that everybody was set up for transfer, like that everybody was going to continue to have a doctor and have a care plan. So every 3 months we run this report. We get all of our patients who are 19 and a half and older, and then our social workers actually meet individually with the different providers to run their list. So I actually just did this with one of our social workers this morning, where I sit down and I look at the list of all my patients that are 19 and a half and older, and I actually like look up each of them in the medical record. I see like, do they have an adult primary care doctor? When am I seeing them next? If I don't have an appointment on the books, I like send a message to be like, call them because we need to work on this. So really making sure that we're keeping tabs on their care. Um, and then the first step is usually to find an adult primary care doctor, is what we try to focus on first. And then that person is able to refer to an adult rheumatologist. We sometimes obviously provide support in that process as well. But just making sure that, even once they age out of their pediatric insurance, that they will have a doctor who can take care of them going forward and get them where they need to be.
That's so interesting, especially that guideline. Like, I wouldn't think, at least here, well, when I transitioned, I was never given this like sheet of paper that told me what my role was or what the process would be. It was like I was doing research on it with other researchers, so I learned about it myself, but I feel like that's not the case for a lot of people and patients that are everywhere. Really, they don't get the same transition experience, and I think everyone's is different, but providing that kind of one pager would have been super helpful. I think even for me, just hearing what it's about. For me, I didn't even know what my role was or what my parents' role was or what the rheumatologist role was in this process, and it was kind of like, okay, we're going with the flow, and I was learning as things were happening. And so do you find that patients that go to, for example, like a community clinic and they transfer care, they have a different experience versus like the academic setting? Like, is there more support? Do you happen to know that?
I do think that we, certainly in the academic setting, in our practice in particular, we are lucky to have as much social work support as we do. Is really important, and it really makes this work possible. I actually did some research during the pandemic with some of my Cara colleagues. Um, Look, so because we were in the process of launching a quality improvement project, a across different sites to try to improve transition processes. And that was like right when the pandemic hit. And so we actually ended up doing some qualitative research with some of our other colleagues to understand why certain sites were successful in getting this project off the ground and others weren't. And one of the things that we found is just having that interdisciplinary team in place makes a huge difference because we're all just one person. And like sometimes, there's like as the rheumatologist, you have a lot of things that you want to address with the patients, and you need to have time and you need to have manpower in order to really do transition in this more structured and thoughtful way. Um, I think that there's a lot of people, who are out there who would probably love to have a more structured transition process in place, but it really, that work really drove home for me that you have to have, that having the resources really just makes a huge, huge difference.
So when the patients are approximately 19 and a half, so is that the age where you start looking towards transition? Because I know a lot in hospitals, at least in Canada, it's sort of 18 years old. We're like, okay, they kind of like get rid of you and transfer you to the next rheumatologist. So is it kind of different by hospital, or is this kind of standard for the age?
So it's really regional. Transition is so local, is another thing to always remember. Like whatever is happening at your center or in your province or in your state, somewhere else might be completely different. So in California, we have a program called California Children's Services, which is a combined state and federal program for kids who are eligible for state insurance. And that program provides really comprehensive chronic illness care. So to get CCS, you have to have what's called a CCS eligible diagnosis, and all of our chronic rheumatic conditions qualify. Um, and then they can stay with me until their 21st birthday, and it really covers like everything that they need. And so we sort of hover around that 21 because that's when our CCS patients need to transfer. I will also sometimes keep my college students until they finish college and know where they're going afterwards. So sometimes that's more like 22. I would say that's more on the outer edge in terms of age, that people follow patients in pediatrics, but it also depends on like the pressures on the health system. So if you have plenty of pediatric providers, then people tend to follow them longer, and the pressures are more on the adult health system. But if the pressures are more on the pediatric health system, that you don't have enough people, but you have more capacity on the adult side, then they're trying to get people out at like 16, 18 to move them over to the adult side, which I think is more what you see in Canada.
Yeah, that's interesting and a good thing to know that it varies where you live, and so it's important to kind of know that. And I was wondering, have you faced any challenges when it comes to this process?
Oh, definitely. I mean, I think having to transfer on your birthday is not awesome for a lot of reasons. Like, ideally, we want patients to transfer when they're ready. And a lot of times that centers around natural events in their lives, things like, finishing college or finishing high school or moving or, getting married or having a baby or, there's like certain times when things happen in patients' lives and it's like, okay, this might make sense to like transfer at this time. Sometimes actually I should mention having a baby is a terrible time to transfer, but that's a conversation for another day. Um, but the bottom line is like, when is this person's disease stable? When does it make sense for them to move to a new doctor and really like to be able to tailor it to their life and their situation? Sometimes for, CCS, we are able to advocate for one additional year for them to stay with us. And this is again where like I've never gone through this process personally. My social workers take care of it because they're awesome. And so that's something we're able to do if we have a patient who, for example, is like very ill and unstable right around their 21st birthday. You don't want to send them to a new doctor when we're right in the middle of like, getting their lupus nephritis under control. So sometimes we'll be able to extend to 22, but yeah, it's complicated for sure. And it doesn't always go smoothly, which is why having people on board to sort of help guide the process makes a big difference.
And then oftentimes you're not only kind of talking to patients, but you're also talking to their parents. How do
Mhm.
you create that inclusive environment for parents to also be involved in their child's health?
Yeah, that's a great question. I mean, it's always interesting to me how different the dynamics can be. Like some families, the parents just like want to be running the whole show, and then I have other, kids, young people, especially from lower resource backgrounds, whose parents are like, they're working, they don't speak English. Like there's reasons why it's harder for them to engage, even if they want to. And so that patient may be more used to like managing things more independently. Yeah, so there's a lot of variation there in terms of like what that looks like. I think that I really try to center the young person because I do think that like developing their skills is so important. Like you don't want someone to go off to college having never had to be like responsible for their own taking their own medications or, calling a doctor. So I really do try to encourage them to really start engaging in the decision-making process. It's not that the parent is cut out, but I feel like if anything, well, I guess it can go both ways. I think like for some patients who have, who are very able to advocate for themselves, but maybe they have like a non-English speaking parent. Like what that looks like is like always making sure you have an interpreter, always making sure that you're like checking in with a parent who might otherwise feel a little bit sidelined because like that's not great either. And then on the flip side, you don't want, the parent like totally running the show. So what that also looks like is like asking the parent to leave for part of the visit so you can talk one-on-one with the patient is really important. And I try to do that regularly, not every single visit, but I try to do it regularly with my patients starting, somewhere between, I'd say like 13 and 15, depending on sort of where they are developmentally.
And then does that kind of help for like the preparation to transfer care?
I would ask you that question, but I think that helping people, I like to just support my patients to have agency over their healthcare decisions. I just saw a patient of mine this morning who I followed for a very long time, and he was here with his girlfriend for the first time, like not with a parent, very independently. He's like a young man now and will be ready to transfer pretty soon. And we were trying to make some decisions about his medicines because he's having trouble remembering to take his methotrexate every week. And we're like, okay, would it be better to take a medicine every week? Should we go up on your Remicade? Like, or would it be better to take a medicine every day? And are you motivated to do that? Or should we just go up on your infusion dose? And he's like, okay, I want to try taking my medicine every day. But I wanted him to say that. Like, I didn't want to say to him, you need to take your medicine every day. Because then I know, he'll go home and who knows what happens. Like it has to come from them. Because at the end of the day, you guys are the ones who got to go home and do all this stuff, right? We have the easy job. We just tell you to do the thing, and maybe just make sure it gets approved by insurance. But I feel like if the patient is not on board, you're not going to get anywhere. So really trying to help them feel like they are the ones who have agency, who are the ones who are like the final decision makers, especially of course once they get over 18. And again, doesn't mean the parent can't be like a voice in that conversation, but like the patient has to have buy-in.
It has any parent kind of said like, no, I'd like to be with my child or anything like that to you?
I can think of maybe once. It's really pretty rare. I think the nice thing is that, I'm not meeting these people for the first time. They've known me for a long time. Hopefully they have, we have some rapport, we have some trust. Um, and I usually will also, like, after I talk to the patient, we'll go check in with the parent independently too. Of course, I keep confidentiality. It's not like I'm going to go report out everything they said, but like I will go out and say, like, I don't think we have anything to worry about, or like this is like high level, some of the things that we talked about, like just so they feel not cut out.
That's really great. I know a lot of parents always have that fear, even like my parents, for example. Even when I have been transferred now to see an adult rheumatologist, my parents are still like in the room. And I mean, it is ideal to potentially have like a few minutes to talk to the rheumatologist alone, but I'm still kind of struggling with that conversation. And I think a lot of patients might be as well. And I recently went to a conference where a physiotherapist was mentioning to me how sometimes it needs to be the healthcare provider that initiates that discussion and says like, "Hey, I would like to talk to Natasha for 5 minutes. Like, I want to do what's best for her," and like, and then kind of reassuring the parent, like you mentioned. But I think a lot of patients just struggle on like, when's the right time to have some of these conversations? How can we bring it up with the rheumatologist, or is the rheumatologist going to be talking to us about, for example, like drugs or alcohol or all those things and interactions with your medications?
Yeah, and where it comes up for me a lot too is we prescribe so many medications that cause birth defects. So I need to be checking in with my young ladies, every now and then to be like, are you sexually active? Are you on birth control? Do you need birth control? And I feel a lot of responsibility as the prescriber of those medications to make sure that we're having those conversations from time to time. And I'm not going to have them in front of the parent. Um, I think the other thing is when I ask about like talking with them alone, I usually frame it as like this is a nice chance for your child to get, to advocate for themselves and get practice talking like directly with the doctor. So I think it's a good developmental step. And I think when you frame it that way too, that helps the parents to understand like, oh yeah, this is really for the benefit of my child.
Yeah. So your educational focus is in health disparities. Can you talk a little bit about what that is?
Yeah, so I have done some research in health disparities and long-term outcomes And that really goes back to, what I was talking about before, my early interest in transition and why some patients, it feels like they go out and they do really great, and other patients really struggle. And I wanted to understand a little bit more about like why that is. I don't do as much research on my own these days. I do collaborate with some of my colleagues, but health disparities research is really about trying to understand differences in outcomes. By certain characteristics among patients. So it's, patients who have characteristics X, Y, or Z are, doing better, and patients who have characteristics A, B, and C are doing worse. Like, what is that about and what's driving it?
And then can you talk a little bit about how these collaborations work with your colleagues? What support do you get and how do you work together?
In terms of research?
Yeah, in terms of research.
Yeah. Earlier on in my career, I was writing more of my own grants. I got involved with CARA, which has provided a lot of opportunities to collaborate with others, to try to understand how we can best support patients in transition, to understand how things are going for our patients who have graduated to adult care, when we can get some data about their, where they're at. And it's interesting, certainly for us, to see how many of them are able to come off medications eventually, how many of them are staying on the medications that they were on. Are they on different medications? How are they doing with regard to their mental health? How are they doing with regard to education and employment? So those are some of the questions that I've looked into. And I would say actually all of the research I've ever done is collaborative to some degree. Some of it I've led more, and some I've participated in a little bit more. But in terms of like what that looks like on a practical level, sometimes it's about working together to write a grant, to fund the research, and whether that's like paying for our time, paying for data sets, paying for statistical analysis in terms of like what that money goes to. Um, and sometimes I'm working with my trainees. So I have been training rheumatology fellows since 2013. And a lot of times I'll get involved in the work that they are doing as they are learning to do the work, to support them and mentor them.
And so what does your day to day look like? I mean, it might look different every day, and I just want to know a little bit about, what do you do on a daily basis at work? Is it research? Is it a mixture of research and going to a clinic or hospital? What is it like?
Yeah, absolutely. So every day is really quite different. And to give a little bit of background, when I finished fellowship in 2013, I was spending a lot of time doing research. But I also around that time, as I mentioned before, started training rheumatology fellows. And I actually found that I loved the educational work. So over time, I've actually pivoted away from research and more towards education. So these days, my job on paper is actually 60% education. So I run the pediatric clinical training for the medical school, which is 40% of my job. I run the pediatric rheumatology fellowship, which is 20% of my job. And I take care of patients, which is 40% of my job. So that's sort of my like on paper breakdown. The reality of that is that like every day is so different. For example, today I had a new cohort of medical students starting on their pediatrics rotation, so I was orienting them this morning. I was meeting with my fellowship coordinator and my clerkship coordinator, for the rheumatology fellowship and for the pediatric clerkship to figure out what we need to take care of this week because it's Monday. Um, I Yeah, and I went and saw some patients over in the clinic. Now I'm back over here recording this podcast. I'm going to try to get home in time to pick up my kid at the bus, which I really like to do, and is one of the nice things about the fact that I don't have to be in the clinic all the time. So I'm going to get home, I'm going to pick up my kid at the bus, I'll take him home, and then I'll work for another couple of hours before the day ends.
I'm glad that there's like a nice balance and you're doing so many different things. So, how do you balance that work-life balance?
I am an obsessive calendarer. So if you ever look at my calendar, it's like all filled in and it has like 10 different colors of all the different kinds of things, but that helps me to feel like, okay, I know when all the different things are going to happen and I have room for it all. So that is a huge crutch for me is the calendaring. And I appreciate that like some parts of my job need to be done in person and some parts don't. So I think having that mix is great. I would never want to work entirely from home. I love seeing patients. I love being in person with my colleagues. I love being like hands-on. Um, and it's nice to have, things that I can work on like curriculum and grading from home and can schedule that around a time when like my kids are going to be home. So I can be working, but also like checking in, if they need help with their homework or something like that. So that for me is like a really nice part of work-life balance. I think people think about, when people think about academics, they think about it being like super demanding and really long hours. And there is a lot of flexibility. And I think it depends on your personality, like if you like that or not. Like some people want to have like a giant brick wall between work and life. And my life is like not that way at all. But then I think that also provides room for me to make each day look more the way I want it to. For example, like if you are a physician who works in the emergency department, like you are going in for a set shift that might be on, Saturday night or Tuesday morning, and you have, and then you might be off all day Wednesday and Thursday, and it's kind of all over the place. I have like more of, my job tends to be um a little bit more Monday through Friday, although I am sometimes on call at night and on the weekend, which for me on a practical level means mostly being available by phone if anyone needs me like overnight or and then going to check in with the patients who are hospitalized during the day on the weekend. Um, and then I do, definitely do work on the weekend, but I do it on my own terms. So it's not like someone's being like, you have to work from this time to this time. I can work it around my kids' baseball or whatever else is going on. And so for me, like, I love that rhythm that I feel like I can sort of manage my schedule so that I have time for my family and for the things that are important to me. And then also like making time to work when it makes sense.
I want to talk a little bit about your initiatives and interests. I mean, you did mention that you're a program director for the UCSF Pediatric Rheumatology Fellowship and also the Pediatric Clerkship Director for the School of Medicine. Can you talk a little bit about what your responsibilities look like?
Yeah. So for the fellowship, it is, yeah, and as mentioned, I've been doing the fellowship for a long time and I love it. We take one new fellow a year and it's a 3-year fellowship. So I have 3 fellows at any given time. They are all like amazing humans. They're pediatricians who are becoming pediatric rheumatologists. And we are really lucky at UCSF we've just have such wonderful people that come in. So they bring, I think, so much to our team. And I really enjoy, the process. So in terms of like what I do, some of it's like very mundane things like dealing with the call schedule. I schedule all our educational conferences, so I figure out who's going to come, teach our team to keep us up to date, and help with sort of the administration and management of all of that. And then some of it's also like, helping my fellows in their job hunts and providing that kind of mentoring and coaching and as they progress along the way. I meet with them every 6 months to talk about like how they're coming along in both their clinical skills as a pediatric rheumatologist and also in their research and their career development trajectories. So I really like that combination of some of it is like actual teaching, some of it is mentoring, some of it is logistics, and it's all those pieces together. And I have certainly a couple wonderful coordinators, one for my fellowship and one for the clerkship that help me with a lot of those logistics too. And then on the peds clerkship side, it's like way more students. So these are medical students that are going into absolutely everything, but I help with their pediatric training. So it's not actually rheumatology specific, it's just pediatrics in general. And they are all going through so med school for the first most part, the first here it's a year and a half. Some places it's 2 years that you're really like doing more classroom learning. So kind of like what you did in college, where it's more, didactics and small groups and lectures and those kinds of things. And then so I start working with the students when they are moving into the clinical part of their training. So now it's more like on the job apprenticeship. It's a huge shift, like a huge transition. Um, and, these folks some of them are going to become pediatricians and like a lot of them are going to become other things. So what I'm thinking about is like, what are the things that all doctors need to know about kids? And then helping them to be, learn what they need to know also to pass all their exams. And so some of that also is like in-person teaching and mentoring, and some of it is also like, supporting people who have, accommodations because of disabilities, like to make sure that, they're successful and getting the support that they need. Some of it is like scheduling, the didactic curriculum and creating the didactic curriculum. What are we actually going to teach them? And some of it is like supporting students who are struggling, and then I have the students actually do their clinical work across 9 different sites all around the Bay Area, and I have a site director at each of those sites. So I'm also in touch with those people and sort of helping to manage things from that perspective as well.
It sounds actually very fun. Like when you're like saying it, I'm like, wow, this is really
It is. It's
interesting.
really fun.
Yeah, it's like a lot of like organizing and like sort of like a leadership position as well too in a way. But I think it's good for other people to know who are listening that these are different like career opportunities and options and things to look into in the future, if they are interested in this side of, healthcare. What advice would you give to patients who have just been diagnosed and may not know where to start when it comes to preparing for rheumatology appointments?
Oh, great question. So I think the most important things to do are to sort of reflect on your symptoms. How happy are you with like how, and I guess, well, you're talking about somebody who's like just brand new diagnosed. Okay, so presumably not happy with how your symptoms are controlled. But I think some things that are good to think about ahead of time is, your doctor is probably going to offer you, assuming you already have a diagnosis, like your doctor is going to offer you some medications. Like, how do you feel about that? How do you feel about taking pills? How do you feel about doing injections? And just to give yourself a minute to sort of reflect on those things. When I'm presenting treatment options, I often, unless people are like, no, we're like ready to go, I will often be like, why don't you go home? If I'm seeing that they're like struggling with a decision, I'm like, go home and think about it. Like, there's no fire. Like, we don't have to decide right in this moment. Go ahead and think about it. And then let's do a video visit. Let's do a phone call in a few days and we can circle up and decide how we want to move forward. But I think to, whatever degree you can sort of reflect on some of that ahead of time. I think that's probably helpful. And then just also keeping tabs on like what are the symptoms you've been having, what's been bothering you, so you're sort of ready to report out on that to your doctor.
When you're informing patients of different medication options, what type of educational materials or how do you inform them about the medication so they fully understand what decision to make?
Yeah, that's a great question. I mean, we do a lot of talking through the pros and cons, and I really try to help encourage them to sort of imagine how this is going to work in your life, like the patient I was talking about earlier today. Like, think about your day to day and what really feels like feasible and realistic for you. The good and the bad thing is we have a lot of choices often, especially when it comes to JIA for medications, and we don't have, in 2025, a way of knowing like, treatment X is going to be best for you as compared to treatment Y. So there is a certain amount of trial and error, but that also means that there are options. So if you were like, there's absolutely no way I'm doing injections at home, like, okay, let's talk about oral therapy options, or if you're like, I would really just rather like do an infusion once a month and like not have to worry about it in between. Like, okay, let's talk about infusion options.
Okay, so there is some flexibility in a way and like different options to see how it actually will be incorporated in their life.
Yeah, I mean, I try to keep a lot of flexibility because the reality is like we don't have data to say like this is definitely the right way to go. When it comes to JIA, I mean, and I guess I should back up and say I'm thinking about this mostly in the frame of, JIA, where we have multiple effective treatment options that are FDA approved, but we don't have head-to-head trials. Certainly when it comes to things like, vasculitis, for example, there may not be as many choices. And we may have better data, especially based off some of the adult trials to say, like, we actually do know in head-to-head trials that this particular medicine is better than that one. And so, of course, when that data exists, I will be like, no, I really think that you should go this way.
Yeah. Okay.
But thinking specifically about JIA, where we do have a fair amount of flexibility, in some ways that's nice because we can, I think I appreciate having the ability to think about what treatment is going to work best for a particular individual patient.
What are some tips that you would give to patients who are transitioning from pediatric to adult care rheumatology?
Practice doing things on your own. Try to not just like let your parents do it for you. Um, get an adult primary doctor is a good, first step, certainly in transfer. I mean, but I think even for patients who are younger, one thing I often encourage is if you have medicines you take every day, get a pill box. Sometimes a good way to sort of practice gaining independence is to have the parent go ahead and fill the pill box. And then instead of like hassling the patient to do it, you give the patient the pill box, give your kid the pill box and have them take their pills. But then keep it in a place where you can check it. So say by like, a certain time, if they haven't taken their pills, then you can be like, hey, you need to take your pills. But that's a good way for the patient to maybe start building some independence, especially in situations where, I know sometimes there can be tricky power dynamics with kids and parents where they're like, take your medicine, take your medicine. And the kid's like, I'm so sick of you hassling me about this. So that I think can provide a mechanism for the patient to be more independent if they want to be, but the parent to also have a mechanism to kind of be checking up on things.
Thank you, Dr. Lawson, for joining me on today's podcast episode. We covered your journey from undergrad to fellowship and your passion for pediatric rheumatology and the challenges that patients can face from diagnosis to transition of care. You shared insights on parental involvement in healthcare, health disparities, and also access to care. We talked a little bit about your leadership roles at UCSF, and in major rheumatology organizations such as CARA. It was amazing and a pleasure having you on the podcast. And everyone like, comment, and subscribe. I'll see everyone in 2 weeks on Take a Pain Check. Thank you.
Thank you so much for having me and inviting me to speak. I love being a pediatric rheumatologist. I feel like it is such a gift and a privilege to get to work with all my patients and to really be able to be a part of their journey and their successes. It brings me a lot of joy. So, yeah, so glad to be able to talk about that today. Thanks, Natasha. Take care.